So let's again just real quick talk about the physiology. Remember that when we take a breath in, obviously we know that oxygen goes into the lungs, and as oxygen goes into the lungs, it diffuses from the alveoli into the serum plasma. That's the very first thing that happens as we enter the bloodstream. Now, as oxygen comes into contact with the plasma, it starts immediately looking for hemoglobin, and about 98% of the oxygen that we diffuse into our bloodstream is going to attach to hemoglobin. Now, as we pass by target cells, as that blood passes by each cell in the body, the oxygen that's in the plasma is diffused out into the cells because there's more oxygen in the blood than there is in the cells. And as the PaO2 starts to fall, as the amount of oxygen in the plasma starts to fall, then the hemoglobin start to release their oxygen. And so essentially you can think of the hemoglobin as being like a storage place for oxygen, and its job is really to backfill the plasma so that as we continue on through the circulatory system, there's a constant supply of plasma oxygen available to be able to oxygenate cells. Now, the thing is, this whole process can go awry, and in order for this process to go awry, we have to understand something called the oxyhemoglobin dissociation curve. This is a very basic but very important tenet of critical care. So when we talk about the oxyhemoglobin dissociation curve, what we're talking about is what the relationship is between oxygen in the plasma and oxygen in the hemoglobin. And when you look at this graphic that we've got in front of us, you'll notice that this graphic obviously is a twofold axis diagram. And when we look at the two axes, the one that's going up, or the y-axis, that is the percent of oxygen in hemoglobin. So this would be our SaO2. The second set of numbers that you see along the bottom, the x-axis, this is the PaO2. This is the amount of oxygen that's in plasma. Now, if we follow these three different curves that you see on this graph, you see there's an A curve, a B curve, and a C curve. Let's focus on the B curve. The B curve, the curve in the middle, would be a normal, healthy person. And you see that when somebody has a normal, healthy acid-base balance, their temperature's where it's supposed to be, all that good stuff, when their physiology is normal, we can plot what we would anticipate that their PaO2 is based on what their SaO2 is. So in other words, we can plot what the amount of oxygen in their plasma is based on what percentage of oxygen is attached to hemoglobin. Well, this obviously is kind of important because we don't sit there and continuously monitor somebody's SaO2, but we do have the ability to monitor their SpO2, or their pulse ox, and their SpO2 and their SaO2 are looking at the same thing. They're looking at what percentage of oxygen is actually bound to hemoglobin. So if we look at normal physiology, you see there that with an SaO2, or if we were monitoring non-invasively with an SpO2, from about 90% to 100%, we have a fairly flat curve when we relate that to the PaO2. So in other words, between 90% and 100%, the PaO2 stays relatively stable. We don't see a lot of change. But where we really see a lot of change, where we really see a dramatic change in that curve, is when the PaO2 the SaO2 or the SpO2 drops below 90. When the SpO2 or the SaO2 drop below 90, we see a significant drop in the PaO2. And remember, that's important because we said the PaO2 is where we get all of our oxygen in our plasma, and that's also where the cells get their oxygen from. So we always emphasize that we always want to keep the SpO2 greater than 90%. Well, that's the big thing we focus on, like when we're teaching RSI, when we're teaching ventilator management, all that stuff. We always say the pulse ox needs to be greater than 90%. Well, in a normal, healthy person, a pulse ox of 90% would assure that you would have a PaO2, if you draw a line straight across from 90% to where that lines up on the B curve, and then you draw a line straight down, a pulse ox of 90% would give us a PaO2 somewhere around 60, 62, somewhere around there. And a PaO2 of around 60, 62, 65, somewhere in there is easily enough to sustain life in a healthy person. That's enough oxygen to sustain cellular metabolism. But when the PaO2 is less than 60, we start to have problems. The lower the PaO2 becomes, the more oxygen is not available in the plasma, therefore the more oxygen is not available for cells, and cells become hypoxic. So when we look at this curve here, we see that when we drop below an SpO2 or an SaO2 of 90, very rapidly we see that the PaO2 drops as well. And once we get to a pulse ox of somewhere around like 50-60%, we've got a significant drop in the PaO2. And once the PaO2 gets to about 30 or so, we're at the point where there's not enough oxygen in order for there to be diffusion from the blood vessels into the cells. So once our PaO2 cuts to about 30 or so, we're in deep, deep trouble, and eventually that would lead to death. Okay, so we've talked about the B curve, and we talked about a normal curve. This curve, this oxyhemoglobin dissociation curve, has the ability to shift either to the right or to the left. And so the curve on the left side, the A curve, would be a shift, what we call to the left. And so if we've got an oxyhemoglobin dissociation curve shift to the left, well, what does that mean? Well, if the patient has had a shift to the left, what that means is that hemoglobin wants to hold on to oxygen. It doesn't readily want to release it. And you can see that when we shift to the left, when we look at our SaO2, we see that our SaO2 at 90% is a substantially lower PaO2 than if we were sitting in a normal curve. So while our pulse ox still may show that we're 90%, if we've had a shift to the left, we really are more hypoxic on a cellular level, even though we don't see that on our pulse ox. Our pulse ox still looks good. We do a blood gas. We see that the patient's, that their SaO2 is still 90%, but in reality, what's happening in the body? Well, the cells are actually getting less oxygen because there's less available in the plasma. So, when we talk about what would cause a shift to the left, there's several things that will occur, or there's several things that can cause that. The first thing to remember again about a shift to the left is when we have a shift to the left, we want to hold on to oxygen. Hemoglobin specifically wants to hold on to oxygen. So while our pulse ox hasn't changed, while our SaO2 hasn't changed, the amount of oxygen in the plasma has decreased and the tissues are getting less oxygen than they need. Now, the first thing that can cause this shift is actually alkalosis. The more alkalotic somebody is, the more they're going to shift to the left. So alkalosis in itself can cause tissue hypoxia because of that shift to the left. Obviously, alkalosis goes hand in hand with low acid, so anytime somebody has a low acid state, they're going to have a shift to the left. The other thing that can cause a shift to the left is a low temperature. The colder someone is, the more their oxyhemoglobin dissociation curve is going to shift to the left, the more the amount of oxygen in hemoglobin is going to go up, but the amount of oxygen in plasma is going to go down, so therefore we have less oxygen actually available to the tissues. And finally, the last thing that can cause us to shift to the left is actually something that we're deficient in called 2,3-DPG, or a low 2,3-DPG. Now, when we talk about 2,3-DPG, 2,3-DPG is actually an enzyme that's present on red blood cells, and it exists to be like a crowbar. Its whole job in life is to pop oxygen molecules off of hemoglobin. So when we have a low 2,3-DPG, it's a lot harder to get oxygen molecules off of hemoglobin. Well, who would have a low 2,3-DPG? The classic example is somebody who has gotten lots and lots of banked blood. When we give somebody transfusions of packed red blood cells, remember that packed red blood cells are stored in a chemical called citrate. And citrate actually works to deactivate, or to kill, if you will, 2,3-DPG. So when you're giving somebody lots and lots of packed red blood cells, those red blood cells that you're giving them still have some 2,3-DPG, but it's not as much 2,3-DPG as normal intrinsic blood would have, the patient's own blood. So the more packed red blood cells we give somebody, the more we improve their oxygen carrying capacity, because that's where we store all of our oxygen at. But also, as a small slight side effect, we're also decreasing the amount of oxygen that's in the plasma. So just because you're giving somebody a bunch of packed red blood cells doesn't mean that you're giving them as much oxygen delivery at a cellular level as they would get if they had an excess of their own blood. So, again, the things that would cause us to shift to the left. Remember that when we shift to the left, we hold on to oxygen, and the 5 things that would make that happen are the 4 things are alkalosis, a low acid state, a low temperature, and low levels of 2,3-DPG. And you can always tell, like, the really inexperienced resuscitator, because when you've got somebody who's like a major trauma patient and you're sitting there and you're watching them, if you don't understand this concept, you may look at them and you may be proud of the fact that you've just given them multiple units of blood, and you may be looking at their pulse ox and saying, okay, their pulse ox is 98%, I'm doing really good. But remember that when we think about resuscitation, we need to be thinking about resuscitation on a cellular level. And if you just gave that patient a bunch of blood, you've given them blood that's got a deficiency in low 2,3-DPG. And the other thing is, usually when we're giving blood in a resuscitation, it's cold, so we've dropped the patient's temperature. So when you're giving that patient lots and lots of banked blood, we are shifting the amount of 2,3-DPG they have. We're shifting their temperature. So because of that, we are also shifting their curve to the left. Now, does that mean that those things are bad? No, they're not bad. Those are tenets of basic resuscitation. But we always need to think not the amount of oxygen that's in the bloodstream. We need to think the amount of oxygen that's in the cells. And remember that when we have a shift to the left, while our SpO2 and our SaO2 are going up, our PaO2, the amount of oxygen that's in plasma, the amount of oxygen that the cells are actually going to have access to, is going down. So we've really got to compensate for that by maximizing oxygen delivery from every level, giving the patient more oxygen, giving them more blood, giving them more cardiac output, doing all these things to maximize the amount of oxygen that's available to them. Okay, so we've talked about a shift to the left. The other thing that we can have is we can have a shift to the right. So if we go over and we look at the C curve, and again we look at our magic 90%, we go straight across. Well, what do you see when we go straight across to the C curve and straight down? Well, you actually see that when we have a shift to the right, what's actually happened is we've actually increased the patient's PaO2. Therefore, we've increased the amount of oxygen in the plasma that's actually available for cells to use. So when we have a shift to the right, the big thing to think about is hemoglobin wants to release oxygen. Hemoglobin wants to get rid of oxygen. So what would cause a shift to the right? Well, here's the good news. As long as you know the things that will cause a shift to the left, it's really easy to figure out what would cause a shift to the right. Because all the things that would cause a shift to the left, if reversed, would cause a shift to the right. So when we talk about things that are going to cause a shift to the right, we're talking about raised acid or acidosis. If you think about that, that makes sense. A shift to the left, we said, would be caused by alkalosis, so a shift to the right would be caused by acidosis. The second thing that would cause a shift to the right would be a raise in the patient's temperature. By keeping the patient warm, we increase the shift to the right. When we talk about shifts to the right, the other thing that can cause a shift to the right is actually a raise in the level of 2,3-DPG. And this isn't something that we really have the ability to control emergently, like we can't give somebody a bunch of 2,3-DPG, but where you really see this is in people who are chronically hypoxic, like your COPDers and CHFers, as they build mechanisms to deal with the fact that they're always hypoxic. One of the things they will often do is increase the level of 2,3-DPG in their body. And finally, the last thing that would cause us to have a shift to the right would actually be a raise in oxygenation. A reduce in oxygenation. Reducing the amount of oxygen would cause us to shift to the right. Now, so when we look at these curves, where do we want to be? Well, obviously, what we would like to do is be in the middle. We would like our patient to be on the B curve. We would like them to be right smack dab in the middle. But sometimes that's not something that we can do. And so if we have our choice of the patient shifting to the left or shifting to the right, we would much prefer that our patient was shifted to the right. You'll always hear intensivists say things like, right is always right. We would much rather have a patient shifted to the right than shifted to the left, because remember, when we shift to the right, while we may see that our SaO2 goes down a little bit, that our SpO2 goes down a little bit, in reality, what's happening is the amount of the oxygen in the plasma is going up. Therefore, the amount of oxygen that's actually available for tissues to use is going up. So we would prefer to be in the middle, but if we can't be in the middle, we would much rather be shifted to the right than shifted to the left. Okay, now let's talk for a minute about the breakdown. We said that in order for us to get oxygen in the blood vessels, we had to have diffusion. There's a couple of places where we can have a breakdown in diffusion, and we quantify respiratory failure. One of the ways that we quantify respiratory failure is in something called the VQ match. V stands for ventilation, Q stands for perfusion. And in a normal, healthy person, the V and the Q should equal each other in liters per minute, roughly. So when we're talking about minute volume, a normal minute volume for a patient is about 5 liters a minute. That's just a rough number. Now, in that same person, their perfusion, their cardiac output should also be somewhere around 5 liters a minute. So we should have a match. We should have about 5 liters a minute of air moving in and out of the chest, and we should have about 5 liters of blood moving in and out of the lungs in any given minute. And if we have that, we have what's called a VQ match. Now there's 2 different types of problems that we can have. The first type of VQ mismatch we can have is something called dead space ventilation. Dead space ventilation is a problem because of cardiac output. The patient with dead space ventilation, their whole issue is that blood cannot get into the lungs. And so good examples of dead space ventilation might be things like cardiogenic shock, where the heart can't effectively push blood up into the lungs, or another good example of dead space ventilation, probably the perfect way to conceptualize this, is a pulmonary embolus. If I've got a pulmonary embolus that's blocking blood flow into the lungs, then I'm going to have dead space ventilation. And what that means is that while air is moving in and out, blood is not. Blood is not catching up with the amount of air that's moving. And the way that we typically see that present itself is we'll see that the patient's PaO2 will fall and their CO2 will go up. Another good example of dead space ventilation would be like cardiac arrest. If the patient's in cardiac arrest and blood's not flowing, then it doesn't matter how many times a minute you bag someone, there's not going to be any blood to pick up that gas. So instantaneously in the blood, what we're going to see is that their PaO2 is going to fall, PaCO2 is going to go up. The second type of problem that we can have, the second VQ mismatch that we can have, is something called venous admixture. And venous admixture is a problem with the lungs. So dead space ventilation was a problem with the circulation. Venous admixture is a problem with the lungs. And with venous admixture, the whole problem is that we're not getting as much air down into the lungs as there is blood flowing through. And since there's not enough air to meet the amount of blood that's coming through, what we see is the patient has ineffective diffusion of gas. And so typically what we see here is that the patient's PaO2 again falls, but in this patient we actually see that their CO2 falls as well. Well, why does that happen? Why does their CO2 fall? Let's think about this. Remember that when we talked about Henry's law and Graham's law, we said that CO2 moves through fluid 20 times faster than oxygen does. So if I'm getting less air to move in and out of the patient, then the amount of air that is getting down there, we're going to see that the CO2 is going to readily diffuse across because it moves 20 times faster. The problem is the diffusion of oxygen. The oxygen is much slower, and so we don't have the physical time we need for oxygen to adequately diffuse into the blood. Now, anytime you get respiratory distress, instinctively, what are you going to do? You're going to start to breathe faster. Well, if I start breathing faster, remember that my CO2 movement is basically a result of my minute volume. So the faster I breathe, the more CO2 I move. So when I've got venous admixture, I basically have hyperventilation. And so while my PaO2 is falling because there's not physical time for diffusion, CO2 can still move adequately because it moves fast. And because I'm breathing fast, I'm moving more minute volume, so my CO2 falls as well. So again, when we talk about a VQ mismatch, we have 2 types: dead space ventilation, which is because of a perfusion problem, and venous admixture, which is because of a lung problem, an inability to get gas in. With dead space ventilation, the PaO2 falls, but the CO2 climbs. And with venous admixture, the PaO2 and the PaCO2 both fall. Okay, so we've talked about, as we're continuing our discussion of oxygen delivery, we've talked about the amount of FiO2 that we have to have. We've talked about where oxygen goes in the blood and how important blood is to being able to move oxygen. The third thing that we have to have is we have to have the ability for that blood to go round and round. We have to have cardiac output. And so when we talk about cardiac output, just a quick review here, we talk a lot more about this in the cardiac section, but just the down and dirty, remember that in order to have cardiac output, you have to have 2 things. You obviously have to have a heart rate, and you have to have a stroke volume. The faster your heart rate is, the bigger your stroke volume is, the more your cardiac output goes up. The slower your heart rate, the smaller your stroke volume, the more your cardiac output goes down. And remember, when we talk about stroke volume, that's actually derived from three things: preload, afterload, and contractility. Remember, your preload is how much pressure is sitting in the ventricle when it's at rest before it takes its next beat. Afterload is what does the heart have to push against. The more vasoconstricted we are, the harder the heart has to work, the higher the afterload. The more vasodilated we are, the less work the heart has to do, the lower the afterload. And finally, the third thing is contractility, which is how well does the heart in and of itself contract. If we've got good, brisk contractility, if we've got a nice, healthy, well-oxygenated myocardium, we're going to have good contractility. If the heart is hypoxic, or if we're missing some of our key electrolytes like calcium, then the heart is not going to contract effectively. So we have to have all three of those things. We have to have an adequate FiO2, we have to have adequate respiratory movement of gas, and adequate respiratory movement of gas and diffusion in the blood, and then finally we've got to have blood movement in the form of cardiac output. So when we talk about oxygen, delivery, there's actually a really common formula that we use in the intensive care unit to figure out what somebody's oxygen delivery is. And the way that we figure out somebody's oxygen delivery is actually driven by the formula that you see there. So if we want to figure out how much oxygen a particular patient is actually delivering in a minute, what we do is we take 1.34 times their hemoglobin times their SaO2. And then we add that to 0.003 times the PaO2, and that actually gives us something called the CaO2. The CaO2 is the content of oxygen that's in the arteries. So I'll say that formula again. 1.34 times the hemoglobin times the SaO2 plus 0.003 times the PaO2 gives us the CaO2, the amount of oxygen that's in the arterial system. Now we know how much oxygen is in the arterial system. If we want to know how much they're delivering in a minute, then all we do is we take that CaO2 and we multiply that times their cardiac output. So CaO2 times the cardiac output, and that gives us a number called the DO2. And the DO2 is the amount of oxygen that's delivered in a minute. Now, this formula actually looks kind of bulky, and there's actually a way we can simplify it. Now, when you look at the first part of that, let's go back and let's look at the CaO2 again. We said the CaO2 was 1.34 times the hemoglobin times the SaO2 plus 0.003 times the PaO2. Okay, when we talk about the PaO2, remember we said the PaO2 was less than 2% of the oxygen that's in the bloodstream. Remember, the PaO2 is the amount of oxygen in plasma, and we said that was less than 2% of the oxygen in the blood. Well, we're talking here, when we look at the math of this, we're talking about 0.003 times less than 2% of the oxygen. Well, that number is so small that it's not even worth paying attention to. So most of the time we just cut out the second part of that formula. And when we're figuring out somebody's CaO2, when we're figuring out the content of arterial oxygen, we just use the top line of that formula. We just say 1.34 times the hemoglobin times the SaO2. That will give us a pretty accurate rough CaO2. And when we want to know how much of that is being delivered in a minute, then we would just say 1.34 times the hemoglobin times the SaO2 times the cardiac output. And it's really important that you understand this, because these are the variables that figure out how much oxygen we're delivering in a minute. Now, one thing I want to point out here is how important the hemoglobin is. When we look at the key factors in that formula to figure out the CaO2, it's 1.34 times the hemoglobin. The hemoglobin is vital to oxygen delivery. Remember, 98% of our oxygen exists on our hemoglobin, so when we cut the hemoglobin in half, we cut oxygen delivery in half. So when you're asking yourself, is my patient hypoxic, it's not about the pulse ox. It's about everything, and everything, one big part of everything, is the hemoglobin. We want to make sure the patient has an adequate hemoglobin. Okay, now that gives us oxygen supply. Now let's look at finally the last part of this whole oxygen delivery thing. Let's look at cellular usage. Remember, in order to have cellular usage, we have to have two things. We have to have the ability for oxygen to get out of the blood and into the cells. And that normally isn't a problem. Most of the time that's not a problem. But the second thing we have to have is the cells have to be able to use the oxygen. So when we talk about oxygen delivery, when we're talking about cellular usage, we have a mathematical way to calculate that as well. And the formula that we use to figure out how much oxygen somebody's using is something called the Fick formula. And the way we figure out the Fick formula is we take the patient's cardiac output times, Q is cardiac output times their CaO2 minus their CvO2. Okay, so let's talk about those two things. Well, we already talked about what the CaO2 was. We said the CaO2 was the content of oxygen that was in the arteries. And we said that the easy way to do that was 1.34 times the hemoglobin times the SaO2. So what is the CvO2? Well, the CvO2 is the oxygen content in veins. And so when we're specifically talking about CvO2, we measure it centrally. So we either measure the amount of oxygen that's coming back into the heart, which we actually would call the SCVO2, or more commonly what we do is we measure the amount of oxygen in the pulmonary artery on its way to the lungs. So we would call that the SCVO2, or excuse me, the SVO2. So the way that we measure the venous oxygen is exactly the same as the way that we measure the arterial oxygen. We take 1.34 times the hemoglobin, and the only variable that we measure that we change is instead of using the SaO2 or the oxygen saturation in the artery, we use the SVO2 or the oxygen saturation in the vein. So I'll say that again. When we're measuring the CvO2, the only thing that we change in the formula, assuming we're using the shorter formula, we're forgetting about what's in the plasma, we're only focusing on what's in the vein, is we just use the 1.34 times the hemoglobin times the SVO2. Okay, so let's go back and let's look at this Fick formula again. The Fick formula says the way we figure out VO2 is the amount of oxygen that's being uptaken by the cells, that's how much oxygen the cells are using, is the cardiac output times the CaO2 minus the CvO2. So probably an easier way to say this is when we look at what the VO2 is, we look at what the patient's, when we're trying to figure out how much oxygen is the patient uptaken, how much are they using, then we look at what is the patient's SaO2, what is their oxygen saturation in the arterial blood, minus their SVO2, which is the oxygen saturation in their venous system. And if you think about that, that makes sense. The more oxygen that I deliver, the more I should get back. But if a patient is using more, then the more I deliver, the less I'm going to get back. So here are the big formulas, and you kind of need to know the basis behind the formulas, but we could even take this whole thing and we could simplify it and we could make it even easier. We could say that in order to figure out the Fick formula, to figure out how much oxygen a patient is using, basically what we need to know is how much oxygen is being provided, i.e. what is their SaO2, and how much oxygen are we getting back, i.e. what is their SVO2. And that really tells us whether or not we've got good tissue usage. And that's really important because that is the last part of oxygen delivery. We have to have adequate oxygen for the patient to inspire. We have to have adequate blood to carry that oxygen. We have to have adequate cardiac output to move that blood round and round. And finally, we got to make sure that it's enough that it's keeping up with the cells, and that's where the Fick formula comes in. It tells us, are we giving the patient enough oxygen to keep up with the cells? And there's a lot of places where we end up with oxygen problems, not because of an oxygen supply issue, but because of an oxygen demand issue. And the classic example of that is sepsis. Okay, now, remember that enough is not always enough. When we think about what normal oxygen delivery is, when you look at all your numbers, let's say you're going to go through and you're going to do your oxygen delivery formula, and you look and you go, okay, well, the patient's cardiac output is normal. I've got a SWAN in this patient. I know their cardiac output's normal. Their hemoglobin is normal. Their SaO2 is normal. So therefore, since their oxygen delivery is normal, they're not going to be hypoxic, right? Not necessarily. Remember that oxygen supply always has to keep up with oxygen demand. And so just because somebody's numbers are normal on the supply side doesn't mean there's always enough oxygen. Because if their demand is up, the normal numbers are not going to be enough to meet the demand. We've got to increase the amount of oxygen to meet the demand. And so probably a great example of that is like when you're exercising. If I was to go and I was to measure your lactate level on somebody who's exercising, then what I would see is that if your SaO2 increased, if your hemoglobin increased, if your cardiac output increased, and all of that increased enough to keep up with the oxygen demand of your cells that are exercising, we would be fine. We would have normal physiology. But let's say that I do something to block that. And we all know that when we exercise, the big thing in that variable that increases is our cardiac output. Well, let's say that I put you on a beta blocker. So now you can't increase your cardiac output, but I still make you go out and run. Well, now, all of a sudden, oxygen supply, while normal, is not enough to keep up with oxygen demand because you're running. And in that case, you're going to end up in trouble. So let's talk about what happens when there just isn't enough, when there's not enough either oxygen or not enough hemoglobin or not enough cardiac output to meet the demands of the cells. Okay, so let's go back and look at this again. We've already touched on this. Let's just hit the highlights. Remember that when we talk about aerobic metabolism, in order to have nice, healthy metabolism, we have to have four things. We have to have two things that go through four phases. The two things we said we have to have, you have to have glucose and you have to have oxygen. If we have glucose and oxygen and we've got nice, good metabolism, then what we see is glucose is converted into pyruvic acid. As it converts from pyruvic acid into acetyl coenzyme A, it goes through the Krebs cycle, it goes through the electron transport chain, and the end result was we made 1 molecule of glucose into 32 to 34 molecules of ATP. Normal, healthy metabolism. Well, what happens when there's not enough oxygen? When there's not enough oxygen because any one of those things that we just talked about broke down. Well, if there's not enough oxygen, glucose can still convert to pyruvic acid because remember we said that was anaerobic metabolism. It takes no oxygen for glucose to convert to pyruvic acid. And as glucose converts to pyruvic acid, we still make 2 molecules of ATP. So we still make a little bit of ATP. But here's where the trouble comes. For me to make pyruvic acid into acetyl coenzyme A, I have to have oxygen. If I don't have oxygen, then that pyruvic acid instead turns into something else. It turns into lactate. And so when I talk about the most sensitive indicator of hypoxia in the human body, it's not what's the patient's PaO2, it's not what's their SaO2, it's not what's their hemoglobin, it's not what's their cardiac output, any of that stuff. It's what is their lactate. The lactate is the most sensitive way to tell if somebody has hypoxia. And we actually have the ability to measure that. And you need to know what a normal serum lactate is. Now, at any given time in your body, there's always some small amount of lactate that's floating around. And so we say a normal lactate is anything less than 2 millimoles when we look at the serum lactate. If the serum lactate goes above 2, between 2 and 4, it's really kind of non-diagnostic. It could be a problem, could not be a problem. But the big cutoff is if the lactate is more than 4. If the patient's serum lactate is greater than 4 millimoles, then that tells you, that is proof that the patient has hypoxia. No matter what you see on your pulse ox, no matter what you see in your hemoglobin, no matter what you see in your cardiac output. If the patient has a lactate that's greater than 4, that patient has hypoxia and that patient is in anaerobic metabolism. Okay, now when we talk about the manufacture of ATP or the breakdown of glucose into ATP. Remember, we said that in normal, healthy people, that breakdown of glucose into ATP created 2 byproducts. The 2 byproducts were CO2 and water. The big thing to remember with anaerobic metabolism is we never get far enough down that chain to make CO2 or water. So really the byproduct of anaerobic metabolism is again lactic acid. So the more anaerobic metabolism we have going on because there's not enough oxygen in the cell, the more lactic acid we produce and the less CO2 and water we produce. Okay, so that brings us to the concept of shock. What is shock all about? Well, if you ask your average clinician what shock is, what we tend to do is we tend to think of shock in terms of signs and symptoms. You'll hear people say things like shock is hypotension, it's tachycardia, it's oliguria, blah, 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 blah. No, no, no. Please just wipe that from your mind. Those are signs and symptoms of shock, but those are not what shock is. Shock is very simple. Shock is when we don't have enough oxygen to meet the demand of the tissue, and therefore the tissue converts to anaerobic metabolism. So what is the easiest, most sensitive way to tell whether or not somebody's in shock? The lactate. If their serum lactate is up, they are in shock. And the advantage to the lactate is that all the other things that we've historically looked at to tell us whether or not somebody's in shock all focused on oxygen supply. But remember that when we talk about shock, you have two things contributing. You have oxygen supply and oxygen demand. If you just look at the patient's hemoglobin, you just look at their cardiac output, and you just look at their SaO2, you can make statements based on that. You can say that if all three of those things are normal, that the patient has adequate oxygen delivery for normal cellular metabolism. But you're completely ignoring the second part of that equation, which is oxygen demand. And if we look at the lactate, it answers all of those questions. It tells us, does the patient have adequate oxygen delivery? And if the answer is yes, then does the patient have excessive oxygen demand? So, if the patient's serum lactate is up, if their lactate is greater than 4, that is proof of shock. That is proof that there is not enough oxygen supply to meet the demand of the tissue. So what do we do when we see that the lactate is up? Well, if we have the ability to get a serum lactate and the serum lactate is greater than 4, then we go back to, is it a problem with oxygen delivery or is it a problem with oxygen supply? So with oxygen supply, we ask ourselves, is the hemoglobin normal? Is the cardiac output normal? Is the amount of oxygen that's in the hemoglobin or the SaO2 normal? If we say yes, yes, and yes, then we know that it is an oxygen demand issue. So at that point, we now know that there's an oxygen demand issue, so guess what we need to do to oxygen delivery? We need to increase it. We need to increase it to meet the demand. And as we increase it, how do we know when we've met enough that we've gotten enough oxygen on board to meet the demand? It's pretty simple. As the lactate starts to fall. As the lactate starts to fall, we know that we are now at the point where oxygen delivery has caught up with oxygen demand. Okay, let's take a break right here, and when we come back with the next section in our respiratory group, we'll talk about acid-base balance and how that plays into all of these different fairly complex physiologic things.
I'd come for you.